Okay, so we're going to spend the next 45 minutes, 40 minutes, because I want to leave a little time on the end for questions, talking about how do we have these conversations, what is the framework of these conversations, and afterwards, if somebody wants that to turn into a TPOPP form, how do you go through that process? So to note that this is a team effort, and that there may be different kinds of people involved in these conversations. We know that the provider taking care of that patient, so maybe a physician, maybe a nurse practitioner, PA, who owns that patient's care, is a critical participant in terms of the medical information and the information that they have around prognosis and what to expect. Can't really have a good goals of care conversation without a good understanding of that medical information. That being said, the doctor is not in this boat alone. That this is a team effort, and there may be other nurses involved, social work, chaplain, and that everybody works together for how the conversations end up happening and get done. So an example, we were doing training in Salina where some of the nurse case managers were like, I'm not going to have these conversations, I don't talk about prognosis. Like, no, you don't. But the doctor may say it once with the patient. You may hear it, and then you may be counseling the patient and the family on the phone for the next 4 days around X, Y, and Z, and that may come up. So we're all engaged in this process, and then using our skill sets along those lines. So important to know that we all have our own roles, and that we all have to kind of play together and own the pieces that are important. It's also critical to say that at the end of the day, if an order set's going to come out of this, the physician has to be engaged in what that conversation was. And that for the veracity of that form to be understood across the continuum, that it's an important conversation needs to be had, that people know and understand. That's good. Know and understand that the doctor or the nurse practitioner was involved. So I'm going to break the box a little bit on the terminology that we use around advanced care planning. I love this slide. This is one slide that I pulled from a training I did in about the last month on serious illness care planning. It was at Harvard through Ariadne Labs. And that there's a little yellow, see that little yellow squirrely thing? That is the kind of the insignia for Ariadne Labs. Any slide that you see that has that on there means that I learned that, and I'm using that slide from the serious illness conversation program. But what I loved about this slide was that it really comes to tell you advanced care planning in our traditional sense is about the planning we do ahead of time that we should all do when we're healthy. Every one of us should have a power of attorney for healthcare, somebody who would speak for us if we were unable. And in the best of circumstances, we've thought about these things in general, and have an advance directive in place. As somebody works through and is now what we'd call seriously ill, where it wouldn't surprise us if they were to die in the next year, things change. And how people think about their goals changes, and how we talk about it needs to change, because there's medical information that needs to come to play from the providers that helps that person contemplate what's important to them and what are their priorities and how do they want the medical system to respond. So that's where we start talking about serious illness care planning, right? Different from advanced care planning. And when somebody's dealing with a different type of prognosis, then, on and on and on for years with no illness defined. So just wanted to kind of keep that in our frame of what are we talking about? What are we talking about here? So how to know when it's time for serious illness care planning instead of regular old advanced care planning? This is tough. So we're going to talk about how should we know? What are some clues that would help us to know that it might be time to have this conversation, right? Because it's a different conversation than you need to have a surrogate, right? So it's hard. We're bad at prognosticating, right? And I'm really glad that I don't know, because from my own little worldview, only God can decide when it's time to go. That's my own personal frame, So it's hard to think about, and there's not a whole lot of, compared to all of the data we have around diagnosis and treatment, the data around prognosis is a lot more scarce. A lot less study has been done on that. And so we have to know that and bring that into account. How we talk about prognosis. Doctors tend to overestimate how long somebody has by a factor of anywhere from 2 to 5 times. So knowing that we tend to provide more optimistic prognoses, you know, for a number of reasons that are coming to be better understood. But that being said, you know, we need to understand the difficulties, but also the necessity of doing the best we can in relation to prognosis. And that we have to own that as medical providers. It's part of our job to be informed. If I don't know it as the palliative care doctor, as the primary care doctor, if it's really the oncologist who would know the most about prognosis, then part of my job is to communicate with that person and say, hey, what's your sense of this, so that they're partners together. There was a support study. This happened in the 1990s. It was a great big huge study that looked at seriously ill patients who are in the hospital, and the goal of that study was to try to improve palliative care at the end of life. So they did an intervention. It was a communication intervention with a nurse seeing the patients and then communicating with the doctors, trying to provide recommendations about symptom management, X, Y, and Z. It was a beautiful intervention. It didn't turn out to work all that great. But there were still several very important things that we learned about the state of palliative care in the United States in the 1990s, and also some other really interesting things. So one of the things they found out was they would ask the doctors of the patients who are in the hospital, how likely do you think it is that your patient will be alive in 6 months? And a high percentage of the doctors were saying, yeah, I think it's pretty likely they'll be alive in the next 6 months. And they were making that statement in the last 48 hours of the patient's life. Anybody been there? All the time. So why didn't the doctors know? So I really think there's probably a lot that goes into that answer, but I don't think that it was the doctors are mean or stupid. I don't. I think we all come to work wanting to do our best job every day, you know, and that there's usually other explanations than obstinate human being who doesn't care, right? We all care. People got into healthcare because they wanted to take care of people, you know, and wanted to do a good job. I'm more inclined to think that functional trajectories and explaining and looking at the functional trajectories can help us to understand why we don't recognize these things sometimes until it's really late in the process. So when we think about functional trajectories, it can also give a little bit of a guide as to when do we start talking about these things and how do we talk about these things. So I'm going to spell these out. A little bit more about functional trajectories in general. This comes from JAMA in 2003. It was a study that took hundreds of thousands of Medicare beneficiaries and then looked back on the patterns of functional decline that they had in the last months of their life. And so this is data, very data driven, that people get on these pathways. So this is the non-cancer illness trajectory. This person's trucking along and then the bottom drops out and they come in the hospital and we tune them up and they get better, but they don't quite get back where they were, right? And they establish a new functional baseline that's a little bit worse, and they truck along at the new functional baseline until, bam, bottom drops out. And they go in the hospital, we tune them up, and they get better, but not quite to where they were before. Who's been there? Who's been there? Yeah, one of the physicians said, that's my entire practice. It is. This is how organ failures and multiple chronic comorbidities add up on a human being, and this is the pattern that they start to show us as they're coming to this one is hard because the timing of it's hard to know. This can go on for months. This can go on for a few years. But the global slope of that trajectory is of a decline. The other hard parts about this is that the bottom can drop out at any point. And I think those doctors did not know. And they said that they thought that person would be alive in 6 months because they were asking them the question 48 hours too soon. right? 48 hours before the time when that person was going to fall off the cliff again, right? And so the pattern is what is important. Recognizing like, man, this lovely patient I love so much, it feels like Humpty Dumpty. And it's taking more and more and more for us to keep her on the wall, you know, and like 4 chips and she's volume overloaded and can't breathe, right? So the pattern is really the important thing there. Guess what percentage of people die on this trajectory? How many do you think? What percentage of people? 100. Not 100, not 100, but 60. 60% of people die from chronic non-cancer organ failures and how that adds up on their body over time. So important to know, this is my bread and butter. I draw this picture for patients and their families as I'm meeting them and saying, okay, tell me about your experience of illness over the last year. And you can identify the drops. And then you can identify, if you ask them, say, tell me about what'd your mom look like? What was she able to do a year ago compared to now? And you can just see it playing out. The hard part about this one is that everybody wants, and they want their loved one to go back to that functional status that was a year ago. They've all got these dot, dot, dot lines. Like, we just do good enough and skilled this time, and if she'll just drink her Ensure, then we get some dot, dot, dots going up, and everything will be okay. And the hard part about that is that when you look at hundreds of thousands of patients dealing with that set of comorbidities, they don't get the dot, dot, dot. So we have to look at how do we help somebody maintain their current function, a pattern of recurrent dropping, then we got to help them prepare for that, right? And help them think through what happens the next time the bottom drops out.
Slide deck's not up.
We're not seeing what you're saying.
So I wonder if people can still hear me. I can just keep
Yes,
talking.
they can still hear.
You're back up. It's just.
Okay. So there's a couple really important things about that trajectory too. The daughter will always come in and say, Dad was fine until yesterday. What went wrong? You know, who messed up? When it's and somebody may have messed up. So you got to make sure nobody messed up. But it may also be the natural consequence of that trajectory and understanding that. You know what that daughter's most afraid of? She's most afraid that she's the one who messed up, right? And she needs to know, I didn't do anything wrong. I love my mom and I'm doing the best that I can. And guess what? I'm not to blame. You're not to blame. This is the trajectory of the illness that's playing itself out. And once we understand that, then people can say, okay, now I've got it. Now I know, you know, now I know what to do. When we identify that pattern, that's the time. Would it surprise me if they were to die in the next year? Now I need to think about a serious illness conversation, you know, so that's one example. So the Lazarus effect. Dad's gotten better 6 other times. He's going to get better this time too. Is that person in denial? Well, they might look like they're in denial, but they're actually just telling you about their experience of illness, you know, because Dad did get better 6 other times. I had a patient, one of my favorite patients ever in residency, and he would go into respiratory failure so easily and need intubated. We all learned how to intubate him, all the residents. He'd been intubated like 25 times, and he'd be on the vent for like a day. Then he'd get off, and he'd go home. And so we love this man. And we all fell into the Lazarus effect. When he actually died, we were astounded. We were like, we didn't think it was possible that he could die, because we got lulled into that sense of everything's going to be okay. So I climb on board with these guys. I think this is the hardest trajectory because it's a roller coaster. You never know when the bottom's going to drop out. You never know if that bottom dropping out is the time their loved one's going to die. And so these guys are stressed, you know, they are stressed and they live with this for a long time, you know. They also think about what matters, you know, what are my priorities if this is happening again. And so it creates a really lovely frame to say, what would matter to you And how do you want us to handle this? This is the frailty dementia trajectory. These guys can live with a very low functional status for a long period of time. And they may be in a place where they're incapacitated for a long period of time. And where our opportunity to have that conversation is earlier on to say, you know, I worry if we hit a place where you're not able to speak for yourself, I'd sure like to know what it is now, because there's a chance with the dementia trajectory that you might live in a state where you can't tell me your opinion, and that might go on for a long time. So while we're in a moment, you know, where you're fine and you do understand what's going on, I really want to know what your values are and what is important to you. And the time to have that conversation is early on, you know, before you, because you may lose, and somebody may lose that capacity so subtly that by the time we think about it, it's too late to really understand what that person had to say. So talking about what this can be hard to see in long-term care, progressive decline, easier to see in retrospect than as it's happening. But if we start asking ourselves a question, would it surprise me if they were to die in the next year? And knowing these conversations are important. Leaves it open-ended about the end. We don't know when the end is. But we do know it wouldn't surprise us if you were dying the next year. And so it's really important to talk about this and know how you feel. So planning for the trajectory. The other trajectory I didn't talk about is cancer trajectory. And that one is about 30% of people. That's when you have a solid tumor that is not responding to therapies, and that person's getting weaker and having more and more tumor burden. You know, and that one is pretty steady when somebody's on that path. That's about 30% of people. Other times where, you know, it's important to be asking yourselves a surprise question. So we also know that there's pretty big gaps between what people say they want at the end of life and what ends up happening. Repeated studies say what people want, if they know that time is coming, they want a comfort-directed approach. They tend to want to be at home. Some of that's changing, but they want to not be a burden on their loved ones. That one comes up near the top of the list every single time. You know, they usually say they don't want their dying to be prolonged. You know, in order to know if we're prolonging living or prolonging dying, we all have to ponder quite a bit. What do we expect from this illness? You know, and how do we help prepare this family? And if we're starting to worry that there's not other things that we can do, we have to be honest about that. So we have to talk about it. We have to be able to recognize the patterns. We have to be able to talk about it. And then we have to get on the same page from the hospital to the facilities to EMS to home. So we spent a lot of time talking about that before. The conversations here are really key. Key to effectiveness for palliative care. Earlier conversations about goals of care for living with serious illness are associated with us doing what they would want us to do more often. Improving quality of life, reducing suffering, better patient and family coping, better patient satisfaction, better bereavement outcomes. So these are all on the quality side of it, you know. It also turns out that if you do a good job at these things, the person ends up spending less money at the end of their life, okay? When we talk about value in healthcare, the definition of value is quality divided by cost, right? If we are providing very poor quality care that is hellaciously expensive, what are we providing? Low value care. If we are providing very high quality care that's also expensive, what are we providing? Potentially high value care, you know? If we are providing high quality care that is also mindful and reduces cost, what are we doing? We're providing very high value care. Not that we need to get into cost discussions, but to know and put on the table that all of these elements of quality palliative care reduce cost, and that improves value. It's not about trying to make people spend less money. It's about improving value in the care that we're providing. So when it comes to these types of conversations, though, we all need to be able to do this. You know, it's part of basic good patient-centered care, how we have these conversations. So me talking with you about having serious illness conversations is a scalable intervention. This doesn't require a subspecialty palliative care doctor, right? And the answer to all our problems is not find a palliative care consultant and check the box, right? The answer is we all got to learn how to do this. Even in my own hospital, I'll tell you, I run a census of about 30 patients on our inpatient palliative care service. And it's an incredibly well-supported service. Our hospital is amazing to us, right? And point prevalence study that showed the day they studied, I had about 26 on my service, and there were 134 patients in the hospital that day who would have qualified for needing some variety of palliative care services. And that was a major light bulb for me, okay? That I couldn't do it. I can't ever take care of all those people on my palliative care service. We've got to all own this and everybody engage, you know, in basic palliative care interventions, of which serious illness conversations are probably the top 2 of what we do, important things. So I'm hoping I'm convincing you to be like, all right, let's have more, better, earlier conversations. So we're going to talk a little bit about this serious illness conversation guide, because these are the tools I was mentioning earlier, you know, about what is the framework that you guys can do. When it comes to communication training, there's a few things that are important to know. One is to recognize that you can have knowledge of it, you can have a tool, but the most important thing is practice, you know. So I'd be very interested if you guys down the line were like, you know what, we're really interested in more training on this, you know, and then we work to build more training around how do we have these conversations and working together in small groups around that. So the outcomes of serious illness conversations, and I think I'm going to show you before we move on to the outcomes, are the 2 tools. We made copies of these 2. Did you guys get these? Okay. So the first one is
the references that Karin is making for those that are online, we will provide to you after the session is completed.
Okay. So the first one is kind of a preparatory thing for your patient. Like, you know what, we'd like to talk about this at your next appointment. And these are some things that you can think about, you know, as we're going into that conversation. Optional, completely optional. The other one is a serious illness conversation guide. And this is a general guide that is patient-tested language around how to have a serious illness conversation. And so I've started using these in my practice. This was what the training was about through Ariadne Labs. So there's elements to these conversations that go in a pretty standardized fashion. Tell me what you understand about your illness. How much information do you want to know? Prognosis and discussion of prognosis to the best that we can. And the doctor doing that, or the nurse practitioner. Knowing that prognosis, what goals are most important to you? What are your biggest fears and worries? What abilities are so critical to your living that you can't imagine living without them? Important question to focus somebody on what's important in their living, being able to do. If you become sicker, how much are you willing to go through for the possibility of gaining more time? And that's where people will tell you what is and isn't worth it to them at that current moment in time for them. And then how much does your family know about this? Because these are not decisions that people make alone, you know, in isolation. And if their family is not aware of the conversation or how they feel, then the family's gonna have a hard time, you know, if they're not engaged, and they need to be included. So these are tools that we're just starting to learn how to integrate even at KU. I offer them to you as a tool, you know. There's a whole other segment of training that goes around practicing with these conversations. But to know there's a structure to this and starting to think about that is important. And helping people think about that in those frameworks. So what if a good serious illness conversation has happened, then like we've talked about before, there may be different types of outcomes. Some people just want to have a conversation, you know. I tend to have these conversations over 2 or 3 visits. I don't try to have this conversation all at one time. So I may answer 2 or 3, And then I may come back to that 2 visits later when another question really feels like it's come time, come time due. Sometimes we have all of that conversation at one sitting. Some people are going to come away from these conversations with a good sense of how they feel about things, Some people, not only do they know how they feel about it, they want orders in place that help to make sure the system understands and that those orders move with it. So that's the time where a TPOPP should happen, and only then. If somebody's not ready to complete a TPOPP form, they should not have a TPOPP form. If there has not been a good conversation with the provider, taking into account the medical information about their prognosis, we should not be filling out a TPOPP form, right? The conversation is absolutely critical. This piece of paper is an outcome. It's an outcome. And then the TPOPP paradigm is like railroad tracks. It's infrastructure that allows the piece of paper to meaningfully move. But you can't do it well without getting all the pieces right. So, have that questions or comments when you hear about that? Okay. So we've talked about who might have a TPOPP form. And now we're going to talk about the TPOPP form itself. So does everybody have one of these guys? So the first section on the form, section A, is a traditional code status order. What would you want if you were in full-blown cardiopulmonary arrest? Full-blown. People either want to get coded, meaning full-blown cardiopulmonary arrest ACLS algorithm, or they don't. It's one or the other. And so a person can use the form to indicate that they do want to get coded or that they don't want to get coded. When I have these conversations with people, usually they're wanting to have these orders in place if they don't want to get coded. The status quo, if they don't have any document with them, the default is that they get coded. And so people don't tend to say, I want this in place, but you can. You absolutely can. What you can't do is say that you want attempt at CPR, attempt to resuscitate me, and then in section B, ask for anything other than full treatment, right? Because if you want to get coded, then you really need to let the medical providers do everything possible under the level of interventions to help avoid you coding. So in going through the form, that's an important thing to bear in mind. The flip side of that, if somebody says that they don't want to get coded in section A, then we have to think about, okay, you don't want to get coded if it comes to that point. But let's say you're getting sicker. You're not coding yet, but you're getting a lot sicker. How do you want the medical system to respond? And section B helps to outline that a little bit. So there's comfort measures only. And that means a treatment goal of attempting to maximize comfort through symptom management only. So these guys don't want poking and prodding. They want you to focus on their symptoms, comfort through the dying process if it comes to that point, right? The next option is limited additional interventions. So these guys have a goal of saying, well, I don't want to get coded, and I don't want you to go crazy, like a whole bunch of machines and stuff, but if I had an infection, why, yeah, you can give me antibiotics. If I need a blood transfusion, you can give me a transfusion, So the basic, at KU, we think about this being the basic things you get on the medical floor, a floor level of hospital care. I'm going to check your labs. I'm going to check your vital signs. We're going to make sure you're working with PTOT. I'm going to treat that UTI. I'm going to treat that pneumonia. All of those things. Yep.
And this also is one of those areas for residents in long-term care communities. This helps to relieve that family's concern if they order do not resuscitate, nothing will be done. And a lot of these additional interventions can be done in the home, in the long-term care setting. They don't have to be transferred to a hospital. So that's important that the family and their patient understand that there's some options available to them.
Mm-hmm. Yeah, sorry. If I get out of my little hospital head. I always sit in my house. Thank you for doing that. So the next section is full treatment. So these guys, they say, I don't want you to code me, but I would want everything up to that point. You know, if all those things aren't working, I don't want you to code me if I actually go on a full-blown cardiopulmonary arrest, but I would want things up to that point. So these guys, they want to be transferred to the hospital if they're having a major change in condition, you know. They may or may want various forms of artificial life support. So somebody who'd say, if I'm coding, don't code me. But if I need to go on a ventilator for 2 or 3 days because I'm in pulmonary edema and you think you can turn that around, that'd be okay. You know, they're not coding yet. So we have to really talk about that. What does that mean? So that's where this idea of DNAR with full treatment comes from. Does that make sense? It can be confusing if you don't think about it along those lines. But from medical intervention standpoint, those guys, and their goal is to try to stay alive as long as possible. And then if they die and they need coded, some of them are going to say, don't code me. That really is what's happening if they go into full-blown cardiopulmonary arrest. Does that make sense? That's the heart of the form is really understanding Section B and how we think through Section B and how we relate with somebody about what their goals of care are. You know, what questions do you guys have when you hear that? Or does it seem pretty clear? That's good. That's good. So we added these treatment goal statements in Section B. This was an example of how the national paradigm adapted. So we added these goal statements because I was like, I don't like the idea of people having to sit there and work through what medical treatments they want. People aren't medical. What are they hoping to accomplish through their medical care? So our aim in writing these goals of care statements was to connect with folks in using non-medical terminology. Say, what are you trying to get out of this? And then we need to match the care plan that we're creating to fit with what your goals are. So we're the first paradigm nationally to add treatment goals. And I don't even know how many now have picked it up, but several other states have picked up the treatment goal language. Because nationally we feed back to one another like, oh yeah, that makes better sense. We need to be doing that. That improves what we're doing.
Well, I appreciate that as an older ICU nurse, of all those patients that were kind of caught in that, don't want to be coded, but gosh, what do you think if they were just on the bed for a couple of days? And a lot of those conversations didn't happen.
Yes.
And so I would like to see those spelled out to where it makes everybody comfortable.
Right. Yeah. Well, so the other piece of that, and there's data that shows that medical providers can overinterpret what a DNR order means, right? I can't tell you, historically, have a patient go to the ICU and have somebody say, well, they're DNR, why are they going to the ICU? And my answer is, are they coding right now? Well, no, they're not coding right now. Well, then why are we talking about their code status? We can't overinterpret the DNR to mean their whole plan of care, but we do, you know? And that was why when I looked at this, I said, this needs to be inpatient and outpatient because we need to know and be more concordant with what we're doing. If we're in the hospital or if we're at home, if we're in the nursing home, and get on the same page with our language, you know? So another study that showed of the people who filled out, this is was a study that was in Oregon, West Virginia, about 890 patients. And they looked at who had DNAR and who had full. And of the folks who completed that they wanted to be DNAR, half of them wanted comfort measures. But the other half of them wanted either limited additional interventions or full treatment, right? And so if we're just saying you're DNR and not further characterizing it, we are very potentially missing 50% of what those people have to say about what they want, right?
Well, and they're not hospice yet, you know, so we wouldn't want to give them more.
So
I think we're getting pushed further to go this way with payment systems because now we're carrying physicians in cities, people in the nursing home where they're admitted to the hospital. And how it has been is the nursing home calls, admitted to the hospital, and then okay, so what do we do? How much? Well, I don't know, we don't see this patient. So I think this is gonna be great for us to have these conversations.
Mhm.
And,
Yeah. So the really key thing in long-term care is to make sure we're separating out the mandatory workflows of the facility with the serious illness conversation and the voluntary nature of having one of these forms in place. Because it's an incredibly useful tool, it will go, everybody should have one.
We're already hearing stories about that.
And it's really important that this remain voluntary, you know, because if somebody has the sense they had to fill it out, then the veracity of that form could potentially go down. And so really staying with the purity of this around serious illness conversation, what's the outcome of that conversation? Would you like to have these in place or not when you're moving? You know, when I've had a good serious illness conversation with somebody in the hospital and they've wanted to define things particularly, 100% of the time they say, oh yeah, I want that moving with me. I've spent time thinking about this. I want people to know what I think. They tend to want to have them. What would you have to add?
What I was going to say was that we started this with Rory's story. That's a good example of someone in a long-term care community that is beginning to tell the staff what they want and how that gets captured then in terms of conversation and then a completion of a TPOPP form. It's a good example in the long-term care world.
So let's see. Okay, so we've talked about,
Yeah.
we've gotten through a lot of these.
Maybe section C.
Let's see.
Those are suggestions.
They're just little examples. So section C of the form is about medically administered nutrition. In both Kansas and Missouri, we have regulation around that. We need to know how people feel specifically about this. You know, if somebody has not expressed how they feel, then the default means do. So until it's medically inappropriate. If somebody's in the active dying process, I know if I give them a bunch of fluid or artificial nutrition, they're likely to throw up, aspirate, et cetera, et cetera. And so there comes a point where it's not medically safe to continue on that pathway. But up until that point, if somebody has an opinion about this, that's why this is on the form, to help make it very clear how somebody feels. There are some people who feel very strongly that they want medically administered nutrition in place as long and up until the very last moment that it's medically appropriate. And you know what? That's perfectly fine. That is okay, as long as it's not hurting them, you know?
Do we have an older form? My deed does not say no, I give foods for vitamins, I give foods for when does it say?
Oh, you have the updated form.
I haven't.
You have the new one. That
Oh,
slide's
that's
old.
the old form.
Oh, the
Okay.
slide is.
Your form
Yeah,
is
yeah,
correct. The
Okay.
slide is old. We've updated.
Okay.
So it's probably before our last update. But what you have in your hand,
This is.
yeah. And so somebody can say they want it long term. Okay, we will respect it to the best of its medical appropriateness. Somebody can say they don't want a tube feeding ever. You know, some people say a trial period's okay. You know, a high percentage of strokes have issue with dysphagia, lose ability to swallow that can come back in a matter of weeks to a few months. You know, that person may say, I want artificial nutrition while I get through this period of time. And if it's working, I'm getting my swallow back, great. They're going to get their peg tube out and go back to eating normally. Other people, they may, after some point, say, I don't want this in place anymore. You know, they can have it taken out, or we can use that peg tube for medicine, for comfort medicine. So at any rate, it's a place where people can state how they feel about it. Section D is about signatures. So and then down below are the places to sign. And so it has to be signed by the patient or their representative, and it has to be signed by, at present, a physician. There is new regulation in the state of Kansas that just became active a few months ago around scope of practice for PAs and signing DNR orders. So we're just getting caught up on how do those regulations play out into this, and we'll update things as we come to know that better. So questions about this? These forms should be reviewed whenever a patient moves across care settings, whenever there's a major change in condition, that would spur, do we need to have another serious illness conversation? And do they still feel the same way as they did in the past? Right, we okay here? Okay. So we've talked about some of this before, but travels between all sites of care, kept in it. So where it's kept in the chart depends if you're EMR or if you're on paper, but it needs to be in a standardized place in the chart for any facility so that everybody knows where it's at. Maybe copies are okay. Faxes also okay. And we treat the original as the patient's personal property. It's bright pink so that that's standardized and easy, easy for identification. The paradigms have different colors. Many of them are pink. A couple are bright yellow, one's bright green. The vast majority of these are pink. EMS is trained to ask, do they have a TPOPP form? In places where this is really...
Or they need to be trained.
They need to be trained.
To ask.
Yeah, they need to be trained.
That's part of the
Training. Yeah. In places where this is really ingrained, in Oregon, if a patient goes into the emergency department who looks like they're seriously ill, terminally ill, the emergency room providers, like, where's their post form? It is a critical part for them of understanding what's the starting point of the goals of care and how they're going to help take care of that patient in the system. So we're a long ways from that, but I really hope we get there someday. So
this is just a resource. This last slide is the resource of the video. It's a 5.5-minute video that we have that explains in a community setting what is TPOPP. It's actually done in Kansas City and Springfield and I think Wichita. So it's a variety of settings, and their images are in the background, but explains in a very succinct form. We're not going to show it today, but it is a link that we can give you, and you can actually use it in a community orientation program. And it really does a nice job of kind of, to the general public, to the community, saying why this is important and what does it include. It has pictures of people filling out forms and getting loaded into the ambulance and going to the hospital, not in an emergency situation, but with their TPOPP form. Kind of normalizes the whole process.
Where's that located?
It'll be it's on our website. You can actually go directly to this link. I don't think this link is working, so it's not going to connect to us. I don't think that the connection is good enough for it to show. But if you just go to our website and type in the TPOPP, the Centers for Practical Bioethics website, or TPOPP website, and then watch the video, you can actually download the link, and it's a YouTube. Is it a YouTube?
Video, but yeah.
Vimeo. Yeah, it's a Vimeo video. You can actually show it in a community setting. Just a nice job of just to the general public explaining what it is. So in your hospital setting or whatever.
I would encourage you to go to the practicalbioethics.org website and just look at what's on there in terms of resources and videos, and there's a whole TPOPP section.
Right.
you have to go under programs. Is that
Go
right?
under the program on the website.
And then TPOPP.
Yeah.
So we have a little bit of time for other questions.
Thoughts, comments?
I think it's going to take a big effort amongst the whole community because, I mean, you know, as the administrator at the nursing home, if we have a resident that doesn't have it and we ship them over here, you know, maybe we failed and could not get the family to talk about this, then it's on the hospital now to try to see if they can't get the family to talk.
There's no requirement to have one.
Right, I know there's no requirement, but, you know, to communicate
Right.
who's had those conversations along the line with the
Yes.
family.
Yeah.
Has the doctor tried? Have we tried at the nursing home? Has the hospital tried? You know, and kind of having those conversations with the community so we know who's tried, who hasn't tried,
Yeah.
who's had the conversation, so we're not all bombarding that
That's a good
family
point.
20 times.
Yeah.
If they don't want to talk about it, they don't want to talk about
Correct. And so I think it's going to make a conscious effort between all the providers around
Right.
to do that.
I think
The other,
go ahead.
the other thing too to figure out is how does the form get from the nursing home to the hospital?
Mhm.
Because even though we've said the patient has it, well, you know the nursing home resident isn't going to sit there with the TPOPP form in their lap, so.
Right.
Yeah.
Right.
I do have to say here, the nursing homes that we work with are really
They're good about getting the
sending-
paperwork.
We probably get more information than what we
Yeah.
need.
Good.
That's good.
But more is better.
Yeah.
sometimes.
Right.
Yeah, so, you know, as a standard part of the nursing home workflow, then to say the document's going to live in this place, and then if EMS is trained, when you walk through the door, you always say, does the patient have a TPOPP form? And the people in that nursing home to go, TPOPP form, I look right here.
Right.
Oh, look, you know, it's just that, who walking through every step of the way. You made a really great point about quality metrics, you know, and how do we measure ourselves and making sure that as we develop the programs, we're developing the quality metrics that actually push us to do the right thing, not the wrong thing, you know. So the wrong thing is 100% of patients must have a TPOPP form, make a checkbox that demands 100%. No. Wrong quality metric, right? So right quality metric is patients seriously, are we identifying the patients who are seriously ill? Yes, no. Are we attempting to have conversations about serious illness and goals of care with our seriously ill patients? And so attempt, you know, is the process of that. Because some people don't want, and you can injure that patient-provider relationship by trying to go there if they're not ready yet, you know. But the attempt, are we figuring out who they are? Are we attempting to address these issues with them? And if the answer is yes, how? What are we doing with the outcomes, you know? And if it's conversations that aren't ending up in documents, how are we making sure that that information is communicated, you know, amongst the community providers? I don't know the answer. I wish I knew the answer. I figured it out in my one little system, you know. In the grand scheme of things, someday this will be in the cloud. We will have cloud charts that unify us, and these documents will live in the cloud, and the RIG will download it from the cloud, you know. That's someday. It's not right now. We're not there yet. And what I argue for in the building of the cloud is that we have ACP document types in the cloud. And then every facility who's going to send information up to the cloud needs to have an ACP note type. So no matter where the note is written, it ends up in the same place in the cloud. And that's how we know the documentation, you know. Now, if only I could get the grant
Maybe before you retire.
to build it. But it will happen. It's going to happen. That is the right thing to have happen. We just need to keep building it step by step to get there. That will help with transportability issues over time, but we are not there yet.
But for the most part, right now, wouldn't you suggest a lot of those conversations start at the primary care visit?
Yes.
and the
That's really where it
provider
needs to happen.
Yes.
Instead of the rest of us trying
Yes.
to
Yes.
have those.
But one of the studies that she's shown too is that,
Right now, that doesn't
you know,
happen.
an episode of care, in an acute episode of care, is usually where it gets started.
But is
A lot
the
of that
right
has
place?
to do with the fact that the questions haven't been broached around how do you know, what do you know about your illness, and what do you want to know about your illness? Do you really understand how sick you are?
Because once they're already acute in the hospital and they have that conversation, they simply write DNR or do BNI or whatever, versus pulling out a TPOPP form, where those would be more common in a clinic where you could have some of those.
Could get originated in any one of the sites of care. You know, if we're really doing a good job of it, where should most of these happen? They should happen with the provider-patient relationship that is known and trusted, you know, because that provider knows that patient the best. And in these types of, I mean, in a large metro area, we have a hard time with that. You know, I hear in smaller communities, you guys are actually able to maintain doctor-patient relationships better and better continuity of care, and that is a major win. That is so good to have engaged provider-patient relationships that go over time, because these conversations are a natural consequence out of that relationship. And it will be much easier for you if you capitalize on that. And that means the office, early, more early, better.
Yeah, in the hospitals, I know in Wichita, almost all the patients are taken care of by hospitalists. So that person really doesn't have a long-term relationship with that,
Doesn't even know them.
with that patient. They're just treating that bout of illness.
That
So-
being said, we have, same at KU, but we have these conversations all the time. I start with, tell me what you understand from the 6 other doctors who take care of you.
Yeah.
And then I help integrate that in, you know. Other questions or thoughts? We're
Well,
almost
and I
out of
think
time.
that tertiary environment is different than what
Yeah.
most of you guys live with. So the fact that, you know, that conversation very likely is not going to happen in a palliative care setting, in an acute care setting for you guys, because this patient's going to be here. So I think your general notion that this is really going to happen in the primary care setting is really important. And I think that's what really will feed and benefit the creation of a community coalition,
And get
because
your
it really
local-
keeps it.
Get your
At the
local
primary care
doctors or a local doctor representative. And we met with them at noontime, and there was quite a bit of interest and information already with your physicians.
Kel said he was on board, so he said, we're on board, is what he said. So you
All right.
Can they be signed by nurse practitioners?
So,
Because so many of, like here, so many of them see them as professionals.
Right.
So
yes. And so I don't want to pass down the letter of the law, but as we are there's the guidance around that is determined by the collaborative practice agreement and what is defined in that collaborative practice agreement. It also is determined based on the institutional policies, you know, that are in place around who can sign what types of orders. And so it is in the details, but am I saying that right? In relation to the jurisdiction and the scope of practice of the advanced practice provider, that is laid out in the advanced practice arrangement.
It sounds to us like that if there was a collaborative agreement with the physician and the nurse practitioner, that is doable. It sounds to us like the current hospital policy doesn't allow that to happen in the hospital. Here in Belton.
So if that gets worked out, in which the collaborative practice agreement, and it probably should need to be explicit in the collaborative practice agreement, that this particular signing of an order is allowed between the doctor and the nurse practitioner, would be okay. The next step would be then, so what does that mean about the hospital policy? Okay, those are 2 separate issues that need to be in 2 different environments and 2 different things.
Correct.
It is in statute and was adopted in 2015 that PAs can now sign DNRs. Okay,
In the state of Kansas,
in the state of Kansas.
in Kansas,
Yes,
but
that-
not nurse practitioners.
well,
Different, they're regulated differently.
yeah, one is Board of Healing Arts and one is Board of Nursing. So Board of Nursing is still, you know, the people we've talked to who are nurse practitioners working in collaborative practice say my practice with my physician says it's okay for me to do this. So it's
That's
because the Board of Nursing governs that.